We know that there are about 800,000 new cases of cancer diagnosed each year in women, and we know about 20% of these people are basically in the reproductive age group. They are probably less than 40. 40% of reproductive age survivors experience the feeling of loss, probably even 50 to 60% of them. Based on a questionnaire or survey, they said that only 5% of women. Thank you. Only 5% of women treated with cancer take actually steps to preserve fertility, and only 60% of women are actually counseled regarding surgery and chemo on fertility, which is a very low percentage. We see a lot of patients in our clinics, and a lot of them are probably not actually counseled regarding fertility options because of the type of cases that we see. But discussion of fertility issues is an important part of pre-treatment counseling for reproductive age cancer patients. I'm going to talk about the gynecologist perspective of it, basically the surgery part of it. I'm going to talk about how we can offer patients fertility-preserving surgery in certain types of cancers, and not all types of cancers. So I'm going to touch about the 3 main cancers. I'm going to start off with cervical cancer. I'm going to move on to endometrial and end up with ovarian. This is what we're trying to avoid. All right. These pictures are from Malaysia. This is where we do our surgeries, and these are types we're trying to, we're taking away the patient's sexuality. We are taking away the patient's infertility. This was a lady in Malaysia. She was diagnosed. She was pregnant. She was about 12 weeks pregnant, and she had a cancer, and we had to do surgery on her because there were no other much options where I come from. So this is what we're trying to avoid. In Australia, it's really good because you all have a very good screening program. I think a screening program is about 80% of your ladies get pap smears. So you all detect your cancers much earlier. So in cervical cancer, it's a really good option to give them fertility preservation options. We know that 45 to 50% of cancers diagnosed in women with cervical cancers, they're usually less than 45 years old. And it's good to offer them if the tumors are less than 2 centimeters. These are the options that we have. In terms of fertility preservation, we've got cone biopsies that we can do, radical vaginal abdominal trachelectomy, and as Silva said, the robot has come into play now. So robots are being used for doing trachelectomies. Neoadjuvant chemotherapies to reduce the size of tumor so that we can proceed with other options like cone biopsies, ovarian transposition, and ovarian transplantation. So cone biopsies basically is where we incise a part of the cervix in a cone shape. And these are suitable for really early stage cancers, which we see here in Australia, those with stage 1A1, where the cancers are basically microscopic. So we can treat them basically with cone biopsies. As we know, because the lesions are so small, the chances of lymphatic spread and parametrial spread is usually about less than 1%. So that is an option for young ladies who want to continue keeping the uterus and their ovaries. Lymphadenectomy is not usually required in these cases because the risk of nodal disease is usually less than 5%, and they have very good fertility outcomes. Ultraconservative fertility sparing surgery in stages of 1A2 have been recommended. However, you need a really good depth of cone biopsy. That means when we make the incision, we'll probably take about 2.5 to about 3 centimeters with cervix off so that we have good margins. But in these kind of cases, you probably have to do a laparoscopic pelvic lymphadenectomy to make sure there's no lymphatic spread. However, in cone biopsies, it's not already really quite safe because it increases the risk of premature delivery. And they say it's about 10 to 15% of these women will deliver before 37 weeks. So in this type of women who had a cone biopsy for early stage cervical cancer, we should offer them cervical length screening when they're pregnant, probably after 14 weeks till about 28 weeks. And I offer them a prophylactic cerclage. Radical trachelectomy. This was introduced by Daniel Dargent in 1989. It's basically we remove the cervix, the upper 1/3 of the vagina, and part of the parametrium. These are usually preserved for stages 1A2, 1B1, where there is a lesion, but it's usually less than 2 centimeters in size. And basically, after we've removed the cervix, the upper vagina, and the parametrium, as you can see, we usually put a cervical cerclage in as a prophylactic measure in case the lady gets pregnant and she would not end up with a preterm delivery. Well, there's a strict criteria when you do a radical trachelectomy. Basically, you need to have a squamous cell carcinoma or an adenocarcinoma. The lesion should be less than 2 centimeters in size. There should not be no metastatic disease, no lymph node involvement, and they must be a good candidate for fertility, probably at age of less than 40. and usually we use them for stages 1A1, 1A2, and 1B1. Preoperative imaging are very important in this group of people, and MRI is, I think, the best preoperative imaging because we need to have a clear and accurate measurement of the size of the lesion. We need to know the degree of extension into the endocervical canal, the length of the endocervical canal, and the distance between the upper margin of the tumor and the lower segment of the uterus. This will give us an idea of how much tissue that we need to remove and whether it should be suitable for a trachelectomy instead of a hysterectomy. The outcome so far with this procedure is that 10% of these patients, when you do the surgery, the procedure needs to be abandoned because once they'll find that the lymph nodes, they do have metastatic cancer. 10% of patients will need adjuvant therapy because of inadequate margins or because of parametrial involvement. The recurrence rate is as comparable of doing a hysterectomy. So this is an option that we can offer patients who have a larger size of tumor, which is macroscopic but less than 2 centimeters in size. The 5-year survival rate is about 97%. Intraoperative and postoperative complication rate is almost similar to doing a radical hysterectomy. The pregnancy rates have been decoded as 40 to 80%, and cervical stenosis accounts for most of the fertility problems. However, there are complications. The problem with radical trachelectomy is that 15% of these women will have cervical stenosis, which will lead them to have dysmenorrhea, painful periods, and infection. The risk of a first trimester miscarriage is similar to the background risk of a normal population, which is about 15 to 20%. However, the risk of a second trimester miscarriages increases to about 10%. So these are figures that you need to tell your patients when you offer them this treatment because they are at risk of having a preterm labor with a baby born prematurely with the complications of a premature baby. The factors why they do have a premature labor is, as I think we can explain, is due to mechanical factors and infectious factors. Mechanical factors is basically because the uterine pressure on a very short cervix, and the infectious factors is because there's an impaired endocervical mucus plug, which we remove during the procedure. Risk factors for recurrence in these patients who go for radical trachelectomy is those with LVSI, which is lymphovascular space invasion, those with larger lesions, and those with neuroendocrine, which are more aggressive kind of tumors. Abdominal trachelectomy is picking up. Most people used to do vaginal trachelectomy, but now abdominal trachelectomy is picking up because it's a much easier learning curve. Most people who are familiar with radical hysterectomy are able to do radical abdominal trachelectomy. It can be used in larger lesions because you can get adequate margins and we can go and get a wider parametrium. The recurrence rate is almost as similar to a vaginal route. Another option that we're looking at is neoadjuvant chemotherapy in patients. What happens if you got a patient with cervical cancer with a large lesion, but she's only about 28 years old? We can offer them neoadjuvant chemotherapy in hopes of reducing the size of the tumor to become less than 2 centimeters, and then we can offer them an ultra-radical cone biopsy or probably a trachelectomy. So this is something that we should be looking at in young patients. However, chemotherapy, as we know, will also have effects on ovarian function. Whether it's partial or complete will depend on the patient's reproductive status, the type of chemotherapy, and the dose of chemotherapy that we give. Ovarian transposition. These are used in patients with young ladies that we have cervical cancers and we want to preserve the ovarian function. What we do is we transpose the ovaries up into the abdominal cavity near the pelvic, the paracolic gutters. The ovaries pre- and post-pubescent girls are more likely to tolerate higher dose of radiotherapy compared to elderly ladies, and if radiotherapy is needed, transposition of the ovaries is an option. It can be used later, so these women, if they want to have children later, they can be used with infertility treatments. They can go for IVF. You can do oocyte pickups from ovaries which are transposed into the abdominal cavity or in the abdominal wall. There's a wide variation of success with this procedure. Some people say it's between 20 to 90%. Some have high, and the reason why is because of the impaired blood flow to the ovaries after you have transposed them, and due to the scattered radiation from the radiation. Oocyte retrieval should be considered prior to radiotherapy in this group of people. Ovarian transplantation is very experimental. We've got two types of ovarian transplantation which we can use. One is autologous, where we conserve the ovaries with the pedicle of the ovary and we implant them into the usually common sites like the forearm or into the chest wall. All right, that's autologous. We use the patient's own ovaries and then they go for fertility treatments and then they do oocyte pickups from the forearms and from the abdominal wall. Non-autologous autotopic transplant is where the patient's ovaries are there, but what we do is take another patient's ovaries which are matched, we strip them off, and we just implant them on the surface of the original patient's ovaries. So we know that most of the oocytes is about 1 millimeter on the surface of the ovaries, so this will regenerate and produce oocytes. So that's about cervical cancer. So these are the options that we can give patients, which are young patients who want to preserve their fertility. In terms of endometrial cancers, the use of progestogens is basically well known, especially in low-risk endometrial cancer. All right, endometrial risk of nodal involvement is usually less than 5% in this group. So look, what do I mean by low-risk endometrial cancer is those with the histological grade of grade 1 and grade 2, where cancer is limited to the endometrium, when cancer is not a high-risk histological subtype, like clear cell. It is crucial that we do MRI for basically preoperative imaging because we want to make sure that the cancer is just confined to the uterine cavity and it's not invasion more than half of the myometrial invasion. And we know that 20% to 30% of the disease will be higher grade or more widespread. Two types of progestogens are commonly used. One is medroxyprogesterone acetate, which we use in high dose, about 500 milligrams a day, and migostrol, which we use about 160 milligrams daily. Complete response rates have been variable, but if you want to use in this type of patients, you probably tell them that it will respond in about 50% of cases. The median time to response will take about 6 months, but the recurrence after complete response will 35%. So if these patients, once they've completed their treatment, once they've completed their family, they should have a hysterectomy. Mirena is being used commonly now. I think we've used them in our setting in patients who are not fit for surgery, which have multiple comorbids, which have very early stage cancer. Mirena can be used. It's used as a maintenance therapy after you've given an oral therapy. It has a response rate of about 40 to 60%. This is the FAM trial that's been going on now, where they have selected patients which have endometrial cancer, they're obese, and they're trying to treat them with progestogen, metformin, and lifestyle modifications. Usually we follow them up with 3 to 6 monthly endometrial sampling, and response rates usually vary between 3 to 12 months. We have good live birth rates, which is about 30%, but as I said, hysterectomy should be advised after completion of surgery. Uterine transplantation, which is coming up new, it's another new form of surgery. It's occurred in Germany, where they've transplanted a patient with a new uterus. So that's something that we can actually look at. And finally, I'll talk about ovarian cancers. Ovarian cancers are very difficult because when they present to us, they usually present very late in stage 3 and stage 4. But with borderline ovarian tumors, germ cell tumors, and early stage epithelial ovarian cancer, there is a role for fertility sparing, which is usually a unilateral salpingoophractomy, pelvic lymph node sampling, and omental biopsies. Borderline ovarian tumors are a very good candidate for fertility sparing because we know they have very low malignant potential, they're very slow growing tumors, they have a good survival rate with just doing minimal surgery. 25 to 30% of these borderlines are basically bilateral. So what you can do is take off the ovaries on one side, do a cystectomy on the other side, and if indicated, chemotherapy. Germ cell tumors, which occur in very young girls, are also a very good candidate for fertility preservation surgery. They are very chemosensitive. The survival rate is between 90%, and majority will resume normal function following chemo, which is a BEP regime. Epithelial ovarian cancers are very difficult because they present to us, as I said, very late, but those with very early stages of one, they are appropriate for fertility sparing surgery, and those who are not, you might want to consider fertility sparing options like oocyte and ovarian cryopreservation. So my take-home message today is that biological parenthood is possible for many women diagnosed with cancer. If you're diagnosed with cancer, your patient's diagnosed with cancer, it does not mean you need a hysterectomy. We need to individualize treatment so that each patient can have an option of having a family. Thank you very much for your kind attention.